So I think it's time to start. We have a wonderful attendance. Thank you to everybody who's here. We are recording this webinar so that we can make it available to people who aren't able to be here now. We were going to try and broadcast it. I think our feeling is that doing that as well as having signing is probably a step too far. We will be circulating the slides via email. As mentioned earlier in the chat, please introduce yourself in the chat and you can ask questions there. Although we do also have a Q&A function, and in theory you can ask questions there as well. That logo is at the bottom is from Sign Live, who are very kindly sponsoring the signing of this meeting, and you can see Ramon and you can't see Orla, who is also involved in this, who between them are providing this service, and we're absolutely delighted that hopefully that means that we are able to make this more accessible to particularly men who use British Sign Language as their first language. So first of all, a few things about the Men's Health Forum. We're a charity, we exist to improve the health of men and boys. We were founded in 1995 by the Royal College of Nursing. We became a registered charity in 2001. We've been an active partner of the Department of Health since 2009. But I don't want to go into too much detail about who we are and what we do. We'll cover a bit of that later on. The main thing is to talk today about men and COVID-19. So what's our objective today? Our goal is, firstly, and we appreciate that so many people are here. We have, as we speak, 80 people in the webinar. Build awareness of the issues about COVID-19 and men's health, consider what needs to be happened, and if we have time, although we need to keep moving, start a conversation about how together we drive the men's health agenda forward and tackle the issues to do with COVID-19 and men's health. The outline, we're in the introduction now. I will then quickly go through the current situation. So what are the facts and figures of COVID-19 in the UK today? Then Professor Alan White, the Emeritus Professor of Men's Health at Leeds Beckett University, will be talking about why are men more vulnerable to COVID-19. And then Peter Baker, the Chief Executive of Global Action on Men's Health and a good friend of the forum, will be talking about the consequences of COVID-19 for men. I've seen a question from Claude Hendrickson saying, is there no video? You should be able to see both Ramon and the presentation slides. It's difficult for me to judge whether that's not happening. If people make some comments in the chat if there's a problem with that, and we'll find a solution. Then Jim Pollard will talk. Okay, can only see your slides. Right, well, okay, good. I think it varies for people, so we'll just keep going. If it gets to the point that it's not clear what's going on, then let me know. So Jim will, my colleague Jim Pollard, who's the creative director of the Men's Health Forum and the editor, will be talking about what we've been doing with the website and online. I'll talk a bit about what we've been doing on engagement, and then if we have time, we'll try and have a conversation about what needs to happen next. So let's start with the current situation of men and COVID-19 in Great Britain today. For reasons, complicated reasons, we tend to focus mainly on Great Britain as a charity, England, Wales and Scotland, because Northern Ireland is part of Men's Health Forum Ireland. In terms of how Men's Health Forum is organised. So today was quite exciting because for the first time, or actually yesterday, Public Health England has started producing a weekly coronavirus surveillance report. And we actually, as of 2 hours ago, suddenly had to chuck in a load of extra slides to bring you up to date with all the latest research. What we have here is a slide we saw for the first time about 2 hours ago, which is laboratory confirmed cases of COVID-19. And what you can see is as you get towards the top, really from 50 upwards, there's more men than women. And then the bottom half below that, there's more women than men. And what we don't have is what the profile of testing is. So this shows us the results of laboratory testing, but what we don't know is who got a laboratory test in the first place. And one key to why the chart looks like this is that the testing has been offered to a mixture of NHS key workers and people in hospital with a medical need. So what we know, and you'll see a chart on this that touches on this later on, that the overwhelming majority of people working in the NHS are women. So about 75% of people, 75, 80% of people working in the NHS are women. So we suspect, but don't know, and need to see the figures to make sense of these charts, that a factor may be that in the younger age group, there are a lot of NHS staff being tested, and that may be the thing that is pushing it towards women being more confirmed cases of women than of men. This is a second thing. This is from GPs. So when people call in GPs and they have either an influenza-like illness or a lower respiratory tract infection, aren't necessarily suspected of having COVID-19, what percent of them are positive? And already here, what's interesting is just on symptom presentation and the testing that follows, we're seeing that men are more likely to be testing positive than women. And this is a second report, and this is just counts up the results of all the tests in Public Health England laboratories. And that also seems to suggest that that more men than women are testing positive. Now we start moving on to what's happening in hospitals. So this slide here shows what is the age profile and gender profile of people being admitted to hospital who receive a lower level of care. There's 2 levels of care in the report, and they haven't. So this is people who don't end up in ICU, as far as we can tell, in intensive care or critical care. And again, what you see here is that overwhelmingly amongst all age groups, apart from 20 to 29, but we haven't got the raw figures yet, so we're just looking at what's on the image. The majority of people being admitted to hospital are men. And if you look at the next slide, there is an age version of this, but we haven't got it in the deck. This is people being admitted to critical care. So ICNARC, I don't know if they call themselves ICNARC, but why not? Started publishing this about 2 or 3 weeks ago. They were the first people to start publishing any kind of gender data in Great Britain. So it was brilliant that they did this. And what they did is they compared admissions, where 72% of admissions into critical care are men, with what happens with viral pneumonia, where normally it's only 54%. And similarly, in terms of advanced respiratory support, 73% of the people of the people in critical care are men, and 68% of people discharged alive who go into critical care are men, and 75% of people who die in critical care are men. So completely disproportionate, 3 times as many men dying in critical care as women. So what's the bigger picture? Well, we're now in a position that the deaths for England and Wales are being presented or published by ONS. They're presented on quite a lag. And what they're showing is that 62% of deaths are men. So again, a 50% higher probability of men dying from COVID-19 than women in England and Wales today. And it's higher amongst every age group. I mean, given that it's a problem that gets worse with age, for the proportions of men and women over the age of 85, for there actually to be more men dying of COVID-19 than women is spectacular, because it is not a 50-50 split at that stage in life. And there's similar figures in Scotland, where it's about, I think, 58% of people. I've seen a note from somebody saying that having difficulty chatting with everybody. There was a problem with the technology. It should now be possible for you to announce yourselves to everybody if you've only been announcing yourself to the panelists so far. And finally, a picture that's quite interesting, and this is us combining data from 3 different sources. So the HSJ, the Health Service Journal, has published an analysis of the inequalities analysis of all the gender split of all NHS staff deaths. And then we've gone to look at figures from NHS employers and NHS Digital to understand what the population is on this. Now, this has been quite powerful data and has had a major impact. And the figures that it got a lot of attention on, that and the ICNARC data, were the overrepresentation of Black and minority ethnic people in the higher mortality amongst those groups. And that's something I think Alan will touch on later on. But this just compares the percent of deaths that are men versus the percent of staff that are men. Firstly, overall, where about half the deaths of NHS staff are men, as opposed to only about a quarter of the staff. Amongst nurses, 40% of deaths are male nurses, and there are only 11% of nurses in total. 94% of deaths amongst doctors are men, as opposed to only 55% of doctors being men overall. Now, there may be age factors in that, in the sense that older doctors are more likely to be men, so that could be a confounding factor, but those figures are very striking. So that's the situation. Those are the figures that we've been able to find in terms of what's happening in Great Britain today in terms of the outcomes of COVID-19, and some early figures in terms of infection. And now I'd like to hand over to Professor Alan White, who will take us through why are men more vulnerable. And I better check that he's unmuted. Good.
Hello.
Alan.
Hello all, thank you very much. Great opportunity to speak to you all. So what do we know? Well, actually, we're still very much at the early stages of all this, and there's still an awful lot we don't know. But if you look at the picture, generally, as far as we can see, there is a similar incidence and prevalence with men compared to women. So we're suggesting that actually, to pick the disease up in the first place, there is some similarity between men and women. However, then we are faster at developing more serious illness. Once we've got beyond the point of developing the basic infection, which attacks the throat, the back of the nose, the back of the throat, we then are seeing men more quickly going down the road of more serious illness, and we're going to look at perhaps why that might be. And we may also be seeing that men recover slower from the virus, and there may be a possible viral reservoir so the disease hangs around the body longer. And so there's an issue around the fact that men may be holding the virus for longer than women. And we've already seen from Martin, thank you very much, about the higher death rate. And I think that's also something of great concern. So if we go on to the next slide, please, Martin. So what are the common symptoms as we currently know? I'm going to explain some about why some of these are important in a second, but the first is the fever. You've got an infection. 80% of mild cases, and actually mild cases, for a lot of people who've had the mild case, it's still not mild. It's still quite a significant illness. And if anyone's had the flu proper, then you realize what I mean. The fever, the cough, the shortness of breath, the muscle pain, tiredness, headaches, and then this loss of taste, smell that people talk about, where it's because it's possibly affecting the olfactory nerve and the taste. And also, people don't realize that there is an issue around diarrhea for some people, because the way the disease is taken into the body, often the digestive tract is engaged with that, involved in that, and I'll explain why in a second. So we have about 80% of these are mild cases, 14% go on to be severe cases, and then 5% are critical, about critical, and then 98% survival. So we're seeing different pictures from different places around the world, but at the moment for the UK, that's what we're getting. If you could have the next slide, please, Martin. So who goes on to get the severe disease? Well, there is something about getting the bigger dosage of the virus, and those people who are working with people or in contact with people who've got the virus are at greater risk because of the fact that they're picking more of it up. It's not just a random effect, it's you're more likely to pick it up. Over 65 is seen as an indicator. And we're seeing something like 80% of deaths in America, in New York, were in people over the age of 65. However, as you've seen from the data that Martin's just showed, that it happens earlier as well. But it's just over the age of 65, we know that we have more of a significant issue. Obesity is also emerging as a very important factor, especially in the severely obese. And this is coming out from America and from the UK data as well. People with cardiovascular problems, hypertension, heart failure are also seen to be at increased risk. People with respiratory disease, existing chronic obstructive pulmonary disease and such like are at greater risk. People with diabetes again with obesity was seen as a principal factor within America, as was hypertension for people who've been at risk, serious risk. Also people with chronic renal disease and liver disease, and people who are immunocompromised, both through, well, mainly through cancer, chemotherapy, and smokers. Could I have the next slide, please, Martin, and probably make more sense of this. So why is a lot of this happening, and why are men more at risk? Well, for a start, one of the principal ways in which the virus gets into the body is via the nose and the mouth, but then to get into the cells, there's a receptor which sits on the cell wall, which is called the angiotensin converting enzyme 2, or ACE2. And that exists within the mouth and nose. It also exists within the lungs. It also exists within the digestive tract. And for men, it also exists within the testes and within various other organs and the kidneys. And so suddenly we're beginning to see why men may be more at risk of getting some of this, the more advanced disease, because of the fact that we are more able to take more of it in. And we also know that that ACE2 is more highly expressed with men who are obese, or patients who are obese, and we know more men are obese than women. Obesity, depending on where you are in the country and where you are in the world, obesity levels vary, I agree. But cardiovascular disease, with the hypertension and the diabetes and the smokers, are all known to have higher levels of ACE2 reception. Over the age of 65, men are more, all people over the age of 65 are more vulnerable, but what we're finding also within the data is that men are becoming more vulnerable at an earlier age, so the younger older. Once we get to the older, we're seeing perhaps similar picture. Obesity, we're seeing a link with metabolic syndrome, epithelial dysfunction, and ACE2. And epithelial dysfunction is emerging as quite an important factor, and that is also more highly prevalent within male. And comorbidity, we also know that from the data from elsewhere, that men have higher rates of cardiovascular disease, renal disease, diabetes, and respiratory problems. So again, we're finding the men are already at an increased risk before we start. There is also an aspect of this, which is women have stronger immune response to infection generally. We've known this for a long time across a broad spectrum of illnesses. It may be linked to estrogen, and for the viruses, the coronavirus, specifically the TLR7 gene, which is on the X chromosome, is highly relevant. And we know that testosterone is immunosuppressive. Martin, could you go on to the next slide, please? Behavioural factors. Smoking is seen both in previous smokers and in current smokers to increase the risk. Alcohol, we're not sure yet whether that's coming through in the figures, but alcohol has been known to be immunosuppressive, and obviously at the present time, people there's issues in the amount people are drinking. Hand washing, there's an awful lot of similarities between this virus and the SARS virus from 2012 and the MERS virus of 2003. And in both those, there was some analysis done and showed that men tended to be not as good at washing their hands. And so there may be an issue in hand washing that needs to be taken into consideration, getting men more vigilant and more rigorous about their hand washing. Denial of risk, people have put forward as an idea that we're just not taking this seriously enough, but it's this massive effort we've been seeing across the country shows that perhaps that is not as evident, but the denial of risk is certainly an issue that may have occurred earlier on, and we are seeing the consequences of behaviour before the lockdown coming through the data. Health literacy, about understanding the issues, I think that also is an important factor, and there may be language issues in asylum seekers, in migrant communities that where people's English has not been, we're not keeping up with getting the messages out. Delayed help seeking. Most of the data around men and help seeking shows that when there's an actual symptom, there's very little difference, and so I think that's a red herring. Working practices, it may be there's issues around how men work within smaller groups, within tight groups, within different settings that may be an issue. And certainly cultural practices differ within relation to religion, for prayers and for some sporting events and public houses, such like. Could I have the next slide, please? We've also seen big issues around ethnicity and race. Now, I've looked into the data and I can't find a biological reason specifically around the coronavirus. You can find that there's issues around morbidity and morbidity around chronic disease and hypertension and cardiovascular disease and diabetes in a lot of the South Asian communities, higher levels of diabetes. But there are aspects of strongly linking ethnicity, race to socioeconomic factors. When we did the State of Mental Health report in Leeds, we found 66% of the Black African community lived in the lowest decile of poverty within the city. So there are strong links between this disease and poverty and crowding and ability to have social distancing and such like. And that crowding also came out from the data that most of the big outbreaks have occurred within settings where there's big crowds, crowding in terms of high density populations, and also more men commute. We know from the data that men are more likely to commute, and a lot of those big groups on trains, cars, etc., trains, buses, etc., where we see perhaps a lot of men at risk before the lockdown. Migrant asylum seekers, as I've mentioned, and access to health services. Certainly abroad, there is a massive issue around how men have access to health services, certainly in America. Could you go on to the next slide, please, Martin? So what we don't know yet is a lot of how this all fits together. We have just starting to get the data around sex, but we don't know how that relates to the sex and the weight data, the sex and the chronic conditions data. And I think that that's what we need to be finding to be able to identify which men are the most at risk. We also haven't got much of the intersectional data, so sex and gender around age, sex and gender around ethnicity. So we're getting the picture around ethnicity, Black and ethnic minority and death, but we don't know how many of them are men, how many of them are women. Socioeconomic status again, and disability again, we don't know how many of those. They're seeing an impact on other diseases. Sexually transmitted infections, there's papers coming out suggesting that's dropping because people are not out. Misdiagnoses because they're not going to the doctors, and delayed treatments. And we know that men tend to suffer from heavy impact disorders and so therefore, if they're missing out on being diagnosed with these heavy impact disorders such as lung cancer and such like, then obviously that may have a serious knock-on effect. Peter's going to talk about mental health in a minute, but the how men are living with this, we just can only assume it's going to be difficult, very difficult for some, but perhaps better for others. We also, because there's ACE2 receptors in the testicles, some papers have suggested there may be a longer term issue about fertility, and men who've had testicular involvement may be wise to have testicular functions assessed. And we also have no idea what the long term impact of this virus is going to be. Thank you.
Thank you very much indeed, Alan. That was extremely helpful. We've got some, we were planning to take all the questions after Peter had gone through his section, but there are some that are particularly medical that I think it might be helpful to get your perspective on, or at least that we can take away and try and find an answer to. Oh, somebody with the exciting name of B074905 has asked the question, if people are taking ACE2 inhibitors, are they more protected?
No, the various guidelines, they're very, very keen that everyone keeps taking every medication that they absolutely need to take, because 80% of the population have mild disorders and will come through this absolutely fine. And it's not to say anyone is going to become worse off because of their medication. The key thing is that everyone sticks to the standard medication, don't change anything. There's some talk about vitamin D, which is because we're all stuck indoors, and vitamin D has an immune effect as well, which is very important. But certainly I don't think anyone should be looking at changing any kind of cardiovascular medication. And they are absolutely necessary. It's absolutely necessary to discuss any changes with the medical team. And don't forget that if anyone goes beyond the level of being mild and goes into hospital, they will be immediately under the care of the experts, and they will take control and they will take all the necessary decisions. So it's certainly not a case of ACE2. Medication should be should be changed.
That's brilliant. Thank you very much. We've got Claude Hendrickson has asked, why do you think more BME men are being infected and dying?
Well, it may be cultural, because of what I'm saying is that we can't find a biological reason. There's not a genetic reason. There's not a physiological reason. What we know is that the people who have more comorbidity, so overweight, hypertension, cardiovascular disease, diabetes, and such like. So there may be aspects in relation to pre-existing disorders that may be more prevalent within the BAME community that has an issue. There may also be cultural factors in relation to shared meals, to multiple community generations living within the same household, religious practice with prayers and such like. So I mean, I think that the Labour, Keir Starmer's just put forward a suggestion that this is assessed, and I think that there's we need to get a closer look at why. But at the moment, there's no biological reason. That's what I'm saying.
Just a question on that, because I know that men are more likely to get BME men are more likely to get diabetes. So
that's what I'm saying. The South Asian community at a lower level of visceral fat develop diabetes. So that there are a proportionally greater number of men from the South Asian community with diabetes.
Okay. And then we had a question, we'll come back to all the other questions later. And there was a question about the link between, let's just see if I can find it, the psychological resilience and the level of general immunity. Somebody had asked that question. I'm trying to see.
Well, shall we come back to that, Martin, and we'll let
Okay.
Peter, because he's looking at mental health as well. So I think
okay, that's a good idea. Let's move on to Peter now, I think. But thank you very much indeed for that presentation. It was excellent and really helpful. Right, Peter, I'm going to switch you on now, and so Peter Baker, my predecessor as Chief Executive of the Men's Health Forum. He's now the Director of Global Action on Men's Health. So he's gone up in the world. And it was now going to take us through the whole discussion about the consequences of COVID-19 for men.
Thank you very much, Martin, and congratulations to the Men's Health Forum for organising this really important event and for attracting so much interest. And good afternoon, everybody. As Martin said, I now have a role with Global Action on Men's Health, and perhaps this is a good moment to say that the kind of picture that's emerging in the UK is broadly in line with what we're seeing internationally. What we're seeing broadly around the world, where we've got data now for over 40 countries, is that men and women are infected with COVID-19 in roughly equal numbers, but the death rates are much higher in men. In virtually, I think in every country, there's not a single country we know about where the mortality rates are higher in women. So this is a global problem. So it's not some kind of, possibly some kind of statistical weird thing that's going on in the UK. We're pretty confident that the increased burden on men is worldwide. If you want to look at some of the global data, I'm going to share a link now. It's just popped up on hopefully on your chat box. This is data collected by Global Health 50/50 based at University College London. And if you go to that webpage, you can see information for every country that publishes sex disaggregated data. But what I'm going to talk about mainly now in the next few minutes is some of the wider consequences for men, looking beyond mortality. Although this is a big topic, at the moment, there's not a huge amount to say because we don't have a lot of data yet. We have some ideas, there's some emerging themes, there's some anxieties that we have about what might be happening for men. But at the moment, it's mostly informed guesswork. But nevertheless, what I hope I can do is highlight some of the issues that we need to think about, which need to be surveyed and researched in the medium and longer term. Next slide, please, Martin. What I wanted to start with is to refer to data that's been collected by our colleagues in Australia at the Australian Men's Health Forum, who have recently done a survey of 50 men's health organisations across Australia. And those organisations identified as the key issues for the men they're working with, social isolation and its consequences for mental health, money and financial issues, which were causing stress and anxiety, family relationships, in particular domestic violence, and for older men particularly, a lot of anxiety around COVID-19 and its possible impact on them. Perhaps that's unsurprising, but nevertheless it's useful to have some data collected from a broad number of organisations about what they're picking up. And it'll be interesting to hear from people taking part in this webinar what issues they're already detecting for the men they're working with or in contact with. Next slide, please. Looking at mental health specifically, we know from the last global recession, looking at data from 2008 to 2010, that men experienced a significant increase in poor mental health. Excuse me, I just lost my slide. Okay, experienced a significant increase in poor mental health as measured by the General Health Questionnaire. This is UK data. And this wasn't explained by differences in employment status over time. So what we know is that recession, economic hardship, and we're going to see a lot of that over the next few years, I strongly suspect, is likely to have a particularly detrimental impact on men's mental health. Next slide, please. And we also know from the last recession that there was a significant impact on the suicide rate in men. For each 10% increase in the number of unemployed men, there was a 1.4% increase in male suicide. So we know there's a direct link between economic recession and the male suicide rate. And again, that's something that we need to think about now if we're going to prevent that happening again in the recession that we're almost certainly going to experience over the next few years. Next slide, please. Alcohol. We know that men generally drink far more than women. Alcohol is a particular problem for men's health. And we're already picking up data from YouGov, who have surveyed 4,000 adults very recently, that about 21% of men are drinking more since the lockdown started. And 4% of those are drinking much more alcohol, and 17% are drinking a bit more. So that's another issue that we need to keep an eye on. Next slide, please. Smoking. We don't have any hard data yet, but there's some anxiety that what's going on will increase smoking rates. And again, men do smoke more than women already, by a smaller margin in this country than in some others. But nevertheless, there's a fear that widespread stress and anxiety will increase smoking rates. Of course, when people are working at home, there's no workplace ban that stops them smoking for a large part of the day. Motivational alternatives like going to the gym or taking part in sport are no longer available. And of course, face-to-face smoking cessation support services have been suspended. Next slide, please. Working life. Well, there's some perhaps pros and cons about what might happen to working life. There may be a possible long-term shift towards home working for many men, which will obviously reduce commuting and create the potential for a better work-life balance. But that could also be counterbalanced by increased unemployment, an increase in precarious employment, people on short-term contracts, 0 hours and so on, as well as a fall in real incomes. So we may see, perhaps for more middle-class and professional groups, an increase in home working with the benefits of that, but for more vulnerable groups, we'll see some possibly very catastrophic effects. Next slide, please. Home life. Well, again, there's some pros and cons here, and this is all speculation. Well, much of this is speculation at the moment. We think that there's an opportunity, clearly, with more men at the moment spending more time at home, for them to be more involved in parenting and childcare, and that can only be a good thing, because although there has been some shift over recent years in men's involvement in parenting, it hasn't shifted as much as we might think. But there is an opportunity now, with men spending more time at home, for them to be more involved in parenting and also in caring and housework. And of course, caring and housework are generally overwhelmingly performed by women, but men at home have an opportunity to get more involved in those tasks. So we could see some shift, hopefully, towards greater gender equality at home. Changing relationships. Well, people are obviously in lockdown spending more time, if they have partners, with their partners, and that may be a good opportunity for some couples to actually improve the quality of their relationship. But for others, it could have the opposite effect, and it could lead to some relationship breakdowns, perhaps at a higher rate than would otherwise be the case. And we're certainly already seeing evidence of higher rates of domestic violence, which is, of course, a particular concern. More positively, again, though, we think we're picking up greater levels of community involvement by men and, of course, by women through volunteering. So that could be a possible long-term positive outcome of what we're going through at the moment. Next slide, please. Just wanted to finish off with some slides about help seeking, because what we're seeing, interestingly, at the moment is a rise in non-COVID deaths. All-cause mortality has gone up in recent weeks, and it can't be explained just by COVID. We don't know much about, we haven't got much data yet, but we are seeing this phenomenon. And there are concerns that men may not be seeking help for non-COVID conditions. We know that A&E departments generally are not very busy at the moment, that GPs are less busy than they used to be. But it may well be that men in particular, because we know that men generally have a greater reluctance to seek help for a wide variety of health problems, that they're not actually seeking the help they may need in greater numbers. The diagrams you can see on the screen are not broken down by gender, but they are indicative of the scale of the problem. So you can see there are sort of cliff edge drop in emergency department attendance recently. Next slide, please. And this also shows the same thing, really. The 2020 line is in pink, the 2019 line is in blue, and you can see that this year, as the lockdown has progressed, there's a really steep decline in people attending A&E departments. We need to know more about why that is and who's being most affected. Next slide, please. This shows the decline in cardiac emissions. Again, you can see on the right-hand side of the graph, a really sharp drop in emissions for cardiac problems in A&E departments in England and Wales. Now this is England, isn't it? PHE data. And again, that's a concern because there's no obvious reason why people should be having fewer heart attacks at the moment, although we don't know if that is the case. But nevertheless, there's a really sharp drop in cardiac emissions, and it may well be the people who need to be going to A&E with a heart attack or a stroke or whatever are not actually attending as quickly as they should. Next slide, please. And this is the trend in GP consultations. And you can see there, while there's an increase in consultations for flu-like illnesses, which presumably includes COVID, there's a fall, a bigger offsetting fall in attendance at GP consultations for other conditions, diarrhea, vomiting, gastroenteritis. So there's a general decline in GP consultations, and it may well be that, as I said, that men are particularly affected by that. Have I got another slide? Oh yes, but there is one positive outcome, potentially positive outcome, that the long-term shift to digital access to primary care might be helpful for some men. And the Men's Health Forum ran a project a few years ago called Man MOT that tested out web-based access to health advice and information from GPs, and it showed, perhaps surprisingly, that there was higher levels of access from younger men and men in areas of deprivation. So while a longer-term shift towards digital access to primary care, it may not work for some men, perhaps particularly in the older groups, but for some other groups of men, it might be helpful. So if the trend towards digital access continues, that might be a useful development for some groups of men. I think that's it, Martin. So thank you very much.
Thank you very much indeed, Peter. I think before we move on to Jim and I talking about what we're doing at the moment, I think it would be helpful to maybe run through the questions and comments that people have been making. We've tried to answer some of them. We've typed answers, and if you look in the Q&A section, you should be able to see those. But there's some other ones where I think I'll either read them out, or I might even ask the people to where they've got a more involved comment to make them in person. So Ruth Armstrong has made the point that most smoking cessation support services are delivering remotely now, and they're promoting that it's actually a really good time to quit because the pubs are shut, and making a point that it's important to try and change the perception of this. And that ties into one of the possible themes to consider in the whole world of COVID-19, which taps into the point that Peter made at the end about, for example, the move towards digital consultations. This may, in some areas, be an opportunity to improve men's health, quite aside from the wider need for us to demonstrate the priority that needs to be given to men's health. Tim's got quite a big point, so I might ask Tim to make it in person, if that's okay. Tim, do you want to quickly sort of talk about your question or reflection? I think I've allowed you to talk. Are you there?
Hi everyone, thank you. That's very kind of you, Martin. Thanks everyone, it's a great webinar. I was just reflecting, unsurprisingly, given my interest and focus on just the points Alan had made, and I think Peter just kind of reflects on it briefly, that whilst we know, at least in the UK, although this is not global, that men will seek care when there's symptoms, if you look at primary health care and preventative behaviours, we know globally and in the UK that men are much less likely to do so, and in fact are far more underrepresented in primary healthcare settings. And I think one of the interesting things when you look at, you know, obesity, when you look at many of the other cardiovascular disease and many of the other causes in relation to COVID-19, I think an interesting question for me is, you know, there are perhaps not quote unquote immediate symptoms that people feel that you would feel for a sexually transmitted infection, for example. And therefore, I think there's less of that urge for men to go and seek care. And so I would argue that because of that, and particularly due to norms around being a man and the association of weakness with seeking care early or preventative care and structural factors within the health service, that I think there is something there around men then, as you say, pre-COVID, being at greater risk. So yeah, that was my reflection. Thank you for an excellent conversation.
Thank you, Tim. I don't know if Alan or Peter wants to reflect on that.
Well, if I go first, the issue with men and help seeking is really complex, and one we really have not yet got to the bottom of. Men have been shown not to be good at preventive healthcare. So if they're overweight or getting in for checks and such like, but even there with colorectal cancer screening, there is actually more similarities than dissimilarities. So it's a really tricky one, and the research that looked at coughs and colds and headaches showed almost no difference. So actually, once the symptoms are there, once they've got the problem, and I just make this point again about the movement from mild to severe. And that actually, by the time you get into the point where you are calling an ambulance or you're going by the doctor, they're really quite poorly. And so I'm not ruling out that some people will stay at home despite that and refuse to call an ambulance. And certainly when I did my research around men with chest pain, you found sometimes men were at death's door before they allowed their wife to call an ambulance. So I think it's going to come out in the wash. I think this is something that's going to be assessed as time goes on as to who died under what circumstances and how many of them were preventable. And I think that's the issue. How many of them were preventable by earlier action, and what would that earlier action have looked like? And I don't think we're at the position yet to be able to say much. I think that the difficulty we have is equity and equality. A bit like the colorectal cancer, we had similar numbers of men presenting, but actually we needed more men to present because men had a higher death rate. So we've got to actually get more men to be drop washing their hands, more men protecting themselves, more men that are vigilant around the risk of developing it, because if they do get it, they might end up with a mild one. But if they've got chronic problems, if they've got obesity, etc., they may more quickly run into problems. So we've just got to be much more vigilant at getting the messages out to the vulnerable men.
Dave Winskill, I think, had an important point about some more excluded groups. So, Dave, would you like to make your comment or about the issue, and then maybe Peter could answer that. I don't know. Is he still there? He might have gone. Right? Dave. So Dave's made the point that there seems to be an issue with care homes, domiciliary care services, prison service, detention centres, people on the street. He's concerned that they're not getting the attention they need, and also concerned about the lack of data about those groups and people in non-NHS care settings. Wonders when it would be possible to do an analysis of the men who receive care in those settings and what might happen. Peter, do you have any perspective on that?
Well, my only perspective really is to agree with what David is suggesting. I think we do need to research all of these issues. I mean, clearly men who are in those very vulnerable groups, and women as well, of course, we need to know what's going on with them. And that's the kind of evidence that we need to, or that's the kind of data that the government needs to be collecting, as well as developing services that actually meet the needs of those particular groups. So I can only agree with David. I think he's absolutely right.
Okay. David Vickers has slightly clarified the question we asked about resilience and a healthy immune system. So Alan, what is the relationship between resilience, mental resilience, I guess resilience generally, and a healthy immune system and the ability to resist things like COVID-19?
I don't think it's as clear cut as we think. I think it depends on how mental and emotional difficulties are affecting the individual. I'd probably be better to give a longer answer later by email. So if he emails in, I can give an answer. So, but in the context, as it's moving slightly outside of this, but I think in what we're more worried about is not so much in terms of them developing the disease, but just in general terms. And I think we have to keep reiterating the importance of people being normal if they have a problem of seeking help, whatever the problem is, because we don't want to find that actually we're making wider range of problems worse by men not seeking assistance. In Leeds, we're doing a lot of work around reaching into the vulnerable groups that we've been working with for years, with groups and such like, and one-to-one calls and Zooms and such like, and actually reaching out as best we can. And we're finding it's been quite effective, but we know that there's an awful lot of guys out there and women that are really struggling with this, and that's going to have to be managed. And I think the more charities like ours can be fleet of foot in changing our practices to be able to support men at this current time, the better.
Okay, that's very helpful. Thank you, Alan. And what we'll try and do, there are still some open questions on the Q&A, is Alan and I and the like will try and answer those questions in passing, in typing, and we'll see if we can get back to some of them at the end. What I'd like to do now is to hand over to Jim Pollard, who will just give you a quick guided tour as to how we're using our website in order to we're using our website in order to help with the whole COVID-19 issue. Jim.
Thanks very much, Martin. I hope everyone can hear me. Good to see so many people still here. This is the point where the whole thing is going to come crashing down around our ears, though, because I'm going to try and take control of the presentation and share my screen rather than Martin. So apologies in advance if it doesn't work. You can see from the slide in front of us that we've got a number of things that we're trying to do on the website, providing information for men in terms of FAQs about health and about staying at home, supporting change, looking at the research. So we've got articles by both Alan and Peter talking about the issues they've been talking about today. We've challenged the UK's ad agencies to come up with a way of communicating with men about COVID-19. And obviously, we're trying to encourage people to fundraise for us and for others working on the men and COVID-19 issue. It's a challenge, though. Men's health's always been a challenge for fundraising, and when the NHS needs all the support it can get, it is particularly difficult. I'm going to try and share my screen now, so apologies in advance if it doesn't work. So I'm hoping someone's going to tell me this, that you can now see our website on your screens. Is that right, Martin? Yeah,
we can see it.
So you can see we're as far as we're concerned, COVID-19 is the big issue in men's health at the moment. And there's buttons, COVID-19 and men, info, research and links all over the website, which will take you to this page, which some of you must have been to already because this is where we were promoting the webinar. So in terms of health information for men, we've got frequently asked questions about the disease itself. We've got frequently asked questions about issues around staying at home. we've got an article which tries to explain social distancing and why it's important, and that why everybody needs to do it, not just those people who might be at higher risk. We also have a video which we've made. I'll come back to that in a minute and play it for you with a bit of luck. We've then got statistics. I mean, people are more and more beginning to provide statistics which are broken down by gender, and we're trying to pull them together here, both for England, Wales and for Scotland. The idea that COVID-19 is just like the flu is a view that's shared apparently by 1 in 4 men, but only 1 in 10 women. So it's important to show the statistics that prove that COVID-19 is not just like the flu, it's considerably more serious at the most serious end. And then there's a number of articles about the percentage of men's deaths, and as you know, we've discussed already, 75% in intensive care, deaths in intensive care are men. Overall deaths, the number's somewhat lower than that, between 60 and 65%, depending on exactly where you look and how you measure it. And we don't really know yet exactly how that proportion is going to break down, because you know, there's still lots of deaths which are not being recorded as COVID, which may actually later turn out to be that. We've then got some research stuff. So we've got Alan talking about men's increased biological risk, and Peter talking about men's behaviours. We've also linked to the BMJ best practice page. If you're a medic, you'll find everything you want to know there, and it's quite interesting for the general reader as well, I think. In terms of what we would like people to do, we've been calling on the government to talk directly to men, to provide data by gender, and we finally, as Martin said right at the top of the webinar, we finally succeeded with that yesterday when they did publish some more information by gender. Previously, we've had to rely on the ONS data, which is several weeks behind. We've also got our creative challenge there, which I mentioned, trying to encourage the ad agencies to help us to communicate with men. We've got our letters to government on the site, and we've also got various surveys that we're supporting that looking at the impact mostly of lockdown and the psychological aspects of it. And then obviously we've got the NHS links as well. What we would really like you to do is 2 things from the website. We'll come on to some other things in a moment. Martin will talk about them. But it's to share our video, which is here, and I'm hoping that this is going to work. So there we are. So that's our very short little video. And we'd also like people to take a look at the 2.6 challenge, which is a thing that's been set up by the organisers of the London Marathon. The fact that the London Marathon's not taking place this year is going to cost the voluntary sector 67 million. And obviously there's many other events which are also being cancelled. And the 2.6 challenge is an attempt to replace that funding for voluntary organisations like the Men's Health Forum with other sorts of activity, and they're encouraging people to think up pretty much anything that they can do, which is about 2.6 or 26, and you can read all about it there, all the various things you can do, and how to sign up to support the forum through doing that. As I said, it is a real challenge because you know, people are raising money for the NHS as well at the moment. That's a very quick whistle-stop tour of everything we've currently got on the website about COVID. Do you want to take control back of the screen, Martin?
Yeah, okay. Thank you very much indeed, Jim. I've just made a comment there, but I've muted myself. So I hopefully now, and I'm muted, and I hopefully now people can see the slides. So we don't want to take up too much of your time. I realise some people are already having to leave and go on to their next meetings. I'll very quickly just talk about what are we asking for. What are we asking for from the government? And this effectively reflects what was in the emails that we've been sending out to people, whether it's the Chief Medical Officer of England, Wales, Scotland, both, well, the Chief Medical Officers of Scotland, Public Health England. We've also arranged for questions in Parliament, other such stuff. So the first thing we're saying, and there has been good progress on that today, PHE are finally doing it, although they haven't released the numbers, and there still needs to be more intersectional analysis, particularly this question of ethnic minority populations and gender, is collecting, analysing and reporting by inequality group, by sex and age, and I'd probably add ethnicity to that as well. The second thing that isn't at all clear is whether the research programme, the NIHR funded work that's going on at the moment, is asking the question about gender and sex, and what exactly is going on. Why are men more likely to be dying from COVID-19, and what are the implications for that? Now somebody's just asked in passing, will we share the results? Yes, absolutely, we will be sharing the results as we come in, and we will put answers up where we think they're helpful, and they add to the debate. The next point, and it relates to the research programme, is understanding how different groups are responding to public health interventions and identifying segmented messaging and interventions. If you look at the Public Health England advertising campaigns, for example, they clearly identified at one point that they had an issue that younger people in general were not fully understanding the social distancing message, and so they produced some special communication for them. I mean, if you get into the figures, it's clear that there are very big gender differences as well, and we'd like to see that kind of thinking going on. It's important, though, that we do have proper understanding as to why people are behaving as they do. So, for example, there was some opinion polling early on that showed lots more people were commuting. Lots more men were commuting than women still, and leaving the home to go to work. And that's partly because many more men work full time, and many more men, and many of them work in industries which can't be done from home. You can't work on a construction site at home. You can't drive a bin lorry from home. And then the last point is we also want gender to be taken into account when they're looking at the impact of social isolation and the interventions needed to control COVID-19. And then there, as is always the way, as we're all learning in these crises, there are new things that appear that need to be understood. So, for example, I don't think people would have predicted that there would be a big fall off in the number of people attending A&E for cardiovascular problems. And we've already written to the British Heart Foundation and to the CBD lead team at Public Health England to say, have you got a gender picture on that? Who are the people who aren't presenting with heart problems? You know, so that interventions and response to that can be done in an appropriate way. So I think we're getting quite near the end of the time we promised. I think we've got about well, I think many people had to finish at 3, but we put it in your diaries, I think, till 3:15. Maybe now any further questions that we've got outstanding that need answering. So Claude Hendrickson has answered, are the government making it easier for men to get tested? And I think the issue there is we don't know, because we don't know what the gender split is of people who are being tested. So one of the things that we find as a continuing obstacle is we don't know what the gender split of people being tested is. And for example, one of the questions that we had, which tied to a very good question somebody was asking about autism, was we don't know we don't know about who's on the shielding list. And we don't know what the equalities analysis is of the people on the shielding list, and what's the gender split, age split, etc., etc. And there's an important point was being asked about you know, poverty. People have touched on poverty. They've touched on mental illness. They've touched on mental disability. They've talked on being in contact with the criminal justice system. You know, we're very strongly of the view that an effective response to any men's health issue is likely to be something that takes different inequalities into account. I don't know if other colleagues want to comment on any of those points.
Testing is the issue. The more testing we can do, the better we are informed, and we've got to be thinking carefully about where these testing centres are set up, how easy it is. I see that they've opened up the website for testing today for NHS staff, and it's crashed already. The numbers are vast, and also testing isn't a one-off test. Doesn't necessarily mean that we're all fine. So there's lots of answers needed about how effective the testing is, how long a negative test has any validity, where are we going to get the testing done, and such like. So I think it's the most important thing after testing is keeping ourselves safe. And I think that's the cultural changes that we're going to have to think about in terms of how we live our lives. And I think that is going to open up all sorts of new issues for people across the sector.
And there's a really interesting, I mean, David Vickers has come back with his question. Well, he's still asking this question about resilience. And I had a thought on that I'd like to sort of discuss and see what other members of the panel think, which is I think we need to be quite careful with this idea that, you know, the strong man is able to withstand a virus. And that, I mean, I think there is genuine resilience and emotional resilience. But what we need to be careful is this paradigm that seems to be touched on, which is, you know, I'm a big, strong guy, and therefore, you know, I won't be able to touch me. And there can be a thing of that, you know, showing weakness, asking for help. I mean, I don't want to misuse the term resilience, but I just wonder if people have any thoughts on that. You know, what are gender norms something that can help men respond more effectively to COVID-19, or do they sometimes stand in the middle, or is it neither one thing or the other?
If it's going to get you, it'll get you, and to victim blame is a real issue that we've got to be very careful. It's not someone's will that they're smitten, and I'm sure Boris Johnson would have classed himself as a very resilient character, and yet he ended up in intensive care. Now, the reason he didn't go into critical care, into ventilation and down the road from there, wasn't because of his personal resilience. It was down to how the virus attacked his body, and that is very much more a physiological issue, predicate that's affected by how the health services are able to respond, and I think the NHS, just to put a flag up for the NHS, is doing a fantastic job in picking people up and giving them the absolute best quality care they could ever give to support people through this, and the death rates would be far higher if we didn't have that. So I just want to applaud all the staff out there that are doing a fantastic job.
I think everybody would agree with that. Some very interesting conversation going on in the chat about masculinities and gender norms and their role in terms of possible campaigns in order to help with COVID-19, and we're going to, in a minute, just a second, I'll quickly touch on what we think might be able to happen next, and we will send an email about this. Holly Whelan asks about stigma issues. She's been reading a lot about it. Do you have any comments on that or insight on that?
Sorry, I missed the question.
So Holly Whelan has written, can you talk about stigma issues you are seeing? Reading a lot about this recently. Maybe.
Oh well, there's a couple of sides to that. One, I think the most important is a lot of the migrant community, the Chinese community, are struggling because of blaming, and I think that has to be. A lot of people move in a lot of different places, and we've got to be careful about stigmatizing people who've had the disease, or are out exercising. And become stigmatized because people think that they're over exercising or they're over enjoying themselves. Or the way we get through this is through normalizing as quickly as we can this new world. And stigma, as we know through all of mental health work that we've done for decades, is a killer, and we should really be making every effort to stamp it out.
Actually, I could, Holly, if you're there, would you like to quickly comment on that? Because I think it'd be useful to get your perspective. I've switched on so that I think you're able to talk now if you want to.
Oh, hi there, everyone, and thanks for a great seminar. I'm really enjoying it. It was just more about how in the research we're doing is that we're worried that going forward, and that's why I'm so interested in inequalities as well, that there's going to be quite a different stratas of society coming out at the end of this. There's the positives could be the community coming together, but the negatives could be very much that different groups are actually stigmatized or really excluded, and that's the thing I was just very interested about, and if anyone had any ideas or research from the past how this can be tackled. But I do agree this is all about mental health and actually getting people to really understand as well what this is about, and actually not blaming different groups.
Absolutely, thank you very much. It is a we've got a lot to learn from the mental health and experiences, and the way we've been working to destigmatize mental health in young men, the Andy's Man Club and the other fantastic initiatives that have been run through CALM and through the forum and what have you. So we as the forum, I suppose, have to be helping support that debate. And what I'd like to be thinking of also is from all of you that are out there is how we as a forum should be helping you. And I'm sure that Martin's going to come on to this, because we are the men's health charity for the UK, for Great Britain, and it's important that we are doing what you need us to do.
That's a very good point. Thank you for that, Alan. You should have moved one slide forward slightly earlier. Yeah, I think we're a bit short now to have that discussion, and we realise that we run out of time. There's a very rich discussion going on the chat. I have a horrible feeling that may stop when we close it. But what we will do is, in the follow-up to this, send out an email which will give you the opportunity to, here we go. This is actually what we thought we might want to do in terms of some of the things we want to do. Firstly is, I think there's clear opportunity here for what you might call a community of interest. So we will send out information about how to join a WhatsApp group to discuss men and COVID-19, and a Google group. I mean, the other option is to convert the current email list, but there may be people who aren't ready to be in a discussion email list. So I'll send an email out about that. And also think about future webinars. We're quite interested, and maybe this could be, I saw that Dan Bell from Men and Boys Coalition is here, maybe talking about support for the sector, for example, could be a useful webinar. We're interested in doing more health information for men. If this turns into a long-term proposition, then I think it would be something where we might want to have a man manual on the topic. We're interested in getting more male targeted advertising. If the government wouldn't do it, we would love to be able to position to raise funds and do it ourselves. We will continue to share the latest research for professionals and people interested in that. And we will continue to work for a stronger gender focus from the health system, particularly on COVID-19. Although this is a terrible situation and so many people are suffering very badly and so many people are dying, you know, if this doesn't enable us to provide an opportunity to put focus onto how men's health is different, and sometimes a gendered approach will lead to better outcomes, then I don't know what will. So here's the link that Jim talked about. We will be sending that round. I'm seeing comments in the chat about wider need for support for the sector, and we have some ideas as to how there are ways into that, and certainly an intersectional approach tends to be better. But we will be sending out an email. We'll be sending out summary of everything that's happened. A big thank you to Ramon for doing the signing, which was brilliant and much appreciated. A big thank you to everybody for all their questions. A particular thank you to Peter and Alan, both for their preparation and for their presentations that they did. And a thank you to Jim for his amazing work on the website, which is such an important asset for us. So that's it. These are our contact details and our Twitter accounts. You will get a copy via email. Thank you all very much indeed for coming along. Apologies for running 1 minute over. And as we all now say to each other, stay well. And thank you very much indeed for coming.